Excellent. So the recording has now started. So welcome to the Pharmacy Foundations online revision course Q&A feedback session. This one is regarding cardiology. I'm sure you guys have seen me or heard from me before if you're watching this session or if you're here live today. My name is Mohammed Imran. I work predominantly as an advanced clinical practitioner in general practice. We've already covered several topics within this course, and we've also done the feedback sessions for them, and we've got many other topics upcoming, as you can see on the screen now. So we've done over-the-counter, genitourinary and malignancy, as well as gastrointestinal and respiratory system, which leads us on to cardiology today. So for anyone that's not attended in regards to Pharmacy Foundations, just a very brief overview, you could say, of the company. We work from undergraduate to foundation year support to even postgraduate, really. Undergraduate, we have workplace learning placements, predominantly in general practice, so a bit more of a clinical environment than in comparison to community pharmacy. We have a clinical simulation suite, which we often use with universities up and down the country, just to give students a bit more of a clinical experience without actually having to be within a clinical environment. And we also offer tuition. Foundation year training support, of course, you've got the foundation pharmacy online revision course. We've got some podcasts, an online mock exam that comes up usually, as well as a calculations masterclass course that'll be released later on this year. Postgraduate wise, we've got CPD learning events and plenty of networking opportunities, as well as clinical simulation to aid the transition into general practice. Let's move on. So this is just a bit of an overview that we had even of last year or even the prior year. In fact, you can see the simulation suite to the left are advanced clinical examination skills, which many pharmacists will pick up in the coming years, especially once they will be qualifying with independent prescribing qualifications from 2025 onwards. There's definitely something really interesting and really important that we can kind of pass on really to the up and coming pharmacists. So then in terms of the company and meeting the team per se, you can see we've got a whole host of individuals that are involved, from primary care to secondary care to community pharmacy even, which is part obviously of primary care. We've also got people that work in academia, such as Atif. I up until very recently was also working in academia. I did that for quite some time, about 3 years or so. So we've got plenty of experience, as well as people that are qualified quite recently as well, which can often give inputs on what you guys are really struggling with and what they struggled with in the prior year to yourselves. So these are our social media pages. Feel free to, of course, give us a follow or a like, etc. on them. And sometimes we do share quite useful things, especially on the Instagram, to be fair with you. We often make 3 to 4 posts a week, which are quite informative and just stimulate some of your thinking and your learning. There's a QR code here as well for anybody that's not in the WhatsApp group already. Feel free to pull out your phone, give this a quick scan. And with that, let's move on. Let's get on to the topic then at hand, which is the cardiology session that we did. So I think I recorded this towards the beginning of this year. I think it was released 2 weeks ago or so, within the first Sunday, I think, of the year. The key things that we covered was the registration assessment framework in regards to the cardiovascular system. We all know it's a high-weighted topic, but what specifically does the GPHC want you to be aware of? What typically will they be asking you questions on? What things will they certainly be asking you questions on? So that's what you can find in the session, as well as we did cover many confusing and complicated topics such as acute coronary syndromes, hypertension, atrial fibrillation, heart failure, as well as strokes and TIAs. And it isn't just that, but I've just kind of made a quick summary. So if these are topics that you're struggling with or topics that you're confused about, it's definitely something to sign up to if you've not already signed up. I will be covering some of these during this session anyway, just to give you a bit of a flavor of what's really on offer. So with that in mind, I would like to give you a brief overview of this session. So you can populate your questions on Slido if you've got any. I'll also be answering a couple of questions that were emailed in. We will revisit some popular sections that students sometimes struggle with or are tricky or I think that you might benefit from learning about. And then we'll have a quick look over Slido, see if you guys have put any questions in there, if you've got anything else you want to ask, which is absolutely fine. On Slido, it's really good because if somebody else asks a question that you were going to ask anyway, you can upvote it. So what that means is I'll definitely be able to have a look at that question for you today, hopefully. If I don't have a chance to look at that question, what I will do is I'll answer it in another session or in the WhatsApp group. So this is the event number for Slido. So literally go into Google, type in Slido. This is only, of course, for the people that are live in this session today. Go into Google, type in Slido, type in this event number, and you can write your question there. I don't think anybody's asked any questions just yet, which is fine. But if you've got any questions specifically in relation to the cardiology system or the cardiovascular system, in fact, feel free to put it in. So with that, then let's have a look at the questions that were emailed in. So you mentioned in the webinar regarding DAPT following MI, how long should it be continued for? That was one question. And the second question is, what is the difference between NSTEMI and STEMI? Okay. How about anybody in the chat? Let's answer question 2 first, because that's a lot more straightforward, isn't it? What's the difference between STEMI and NSTEMI? I'm going to give you guys a few minutes. Feel free to have a bit of a guess. And then we'll have a brief talk through what it actually is. And I'll feel free to DM me as well if you don't want to share with everybody, by the way. You can just change the to. When you're typing in a message and it says to, you can just drop down and change it to my name if you'd like. But have a stab in the dark if you don't know. It's not a problem. Or which one of these two is most severe then? Are we more worried when somebody has a STEMI, or are we more worried when somebody has an NSTEMI? STEMI is more dangerous, right? That's correct. Excellent, excellent idea. That's correct. So a STEMI is when there's a complete blockage, right? So, for example, we have coronary blood vessels. So these are blood vessels that supply the heart muscle itself with blood. A STEMI is when there is a blockage within one of these coronary blood vessels. So this stops the circulation of blood flow to a particular section of the heart, therefore leading to hypoxia and leading to tissue death. That's what ends up causing the pain within MIs. Now, this can be acute due to a rupture of a plaque or thrombosis even. However, it can also occur due to coronary vasospasm. So main thing that you want to learn is STEMI is more dangerous, point 1. It's when there's a blockage and it stays in place, that blockage. And NSTEMI, there's a blockage, but it's transient, so it's short term. So the blockage stays in place and it's usually some sort of plaque that ruptures or some sort of thrombus. Now, in terms of plaques on coronary vessels, what are we most concerned about? What causes the plaques on coronary vessels quite commonly, unfortunately? What do we think? It is cholesterol, correct. Cholesterol is one of the key things that actually causes a build-up and causes the blocking of coronary arteries. The second thing that can cause this is, so one thing was a blockage. The second thing is coronary vasospasm. So think about it. You've got a blood vessel that's quite thick. Let's just say that's your blood vessel, quite thick. And vasospasm is, in essence, that's caused it to close. Okay. So think, what are the possible causes of coronary vasospasm? What do we think? So some people, they will have a STEMI when they're really, really stressed out. So they're really worked up. So stress can be a factor in causing coronary vasospasm. So even with people with angina, they can even have coronary vasospasm. Obviously, that causes cardiac pain. Other things, you've got things like cocaine, amphetamine, alcohol, withdrawal even. All these things can cause coronary vasospasm. I can see there's a question in the chat. I'm going to hopefully answer that after these two, if that's okay. So in terms of the ECG reading, you have so an ECG looks like this. It's P, then it goes Q, R's at the top, S is underneath the x-axis, you could say, if you were to draw a graph. So it's when there is depolarization and repolarization of the ventricles. So when that's elevated, that means that the ventricles are not depolarizing and repolarizing effectively. Hence, the patient is having a STEMI. Now, an NSTEMI, that's more usually associated with a narrowing of coronary arteries, which is chronic, long-term, as well as atheromatous plaques, which is often lipids, and it can also be caused by transient occlusions, such as blood clots even. Now, the risk factors for plaques in general, and we know that the plaques generally are caused by lipids. So one of the risk factors is obviously having a poor diet. Also being obese, which is also usually associated with a poor diet. Other things could be things such as hypertension, a lack of activity, uncontrolled diabetes even. That can often cause microvascular complications, and we'll be talking about microvascular complications on the endocrine session upcoming later this month. Smoking as well is another one, as well as increasing in age. All these risk factors increase the risk of plaques forming on coronary blood vessels in general, and therefore increase the risk of MI, regardless of STEMI or NSTEMI for that matter. Cool. So let's move to the first question then. So you mentioned in the webinar regarding DAPT following an MI, and how long should this be continued for? I think this is a really good question, because up until relatively recently, we always used to say 12 months, 12 months, 12 months was pretty much all you guys probably ever heard of. But now when we look at the guidelines, it actually can be considered to be continued for up to 36 months, right? So up to 3 years. Key point here is the GPHC is not actually going to get you to say how long something should be continued for if there's a question about it. The key thing is going to be usually DAPT is for 12 months following MI, right? However, in certain situations, and I'll illustrate them to you in a moment, we will continue the DAPT for a longer period, up to 36 months, okay? But let's take a step back. So we're talking about antiplatelet therapy here. So dual antiplatelet therapy, or even antiplatelet therapy for that matter. Let's think about it. When's that usually indicated? We know it's indicated following an MI because that's currently what we're discussing. But when else is antiplatelet therapy indicated? What other conditions? Stroke, yep. TIA, yep. Anything else? Or is that it? What AF is good, potentially. Potentially. There's a better option in AF as opposed to antiplatelet therapy. So we've got anticoagulants versus antiplatelets in AF. That's the common kind of debate that students have. And they're not quite sure which one to use. Any other conditions that you can think of that we might need to give somebody an antiplatelet? What about heart failure? Are you going to give somebody an antiplatelet if they've got heart failure? Yes or no? Easy question. No, we're not. Heart failure is not indicative of taking an antiplatelet. Okay, so the conditions that would indicate that a patient should be on some sort of antiplatelet are so acute coronary syndromes, which is MI, STEMI, and NSTEMI, and angina, uncontrolled or controlled for that matter. AF, possibly we would use antiplatelets. However, in AF, we have a preference of using DOACs or warfarin over using antiplatelets for stroke prophylaxis in AF. Much more effective. However, if the aforementioned DOAC or warfarin is not indicated, tolerated, or unacceptable by the patient for any particular reason, then we can consider antiplatelets as an alternative. Other places where we would also want to use antiplatelets would be peripheral artery disease, so PAD or peripheral arterial disease, in fact, sorry. Also following stenting, which is usually after NSTEMI, and of course, as we mentioned already, following a stroke. Now, in terms of when something should be prescribed, in angina, if it's stable or unstable, we typically would use something like aspirin. An alternative would be clopidogrel, unless aspirin, if aspirin for whatever reason was contraindicated. Contraindications, obviously, for aspirin can be quite varied. So it could be from things like GI ulceration to things even such as asthma, or even if a person is allergic to aspirin. Okay, so you want to be thinking about the fundamentals behind prescribing. So that could be something that comes up in an exam. So they could give you a list of different antiplatelets. So the key ones that you should remember, or you should be aware of at least, is aspirin, clopidogrel, ticagrelor, prasugrel. There's another one as well. Starts with D. What is it called? Disopyramidol. Yeah. So somebody could quite easily, or the GPAC could quite easily give you a question and say, patient's got angina, they're asthmatic. What would be the first line treatment antiplatelet for this patient? So that would be clopidogrel, right? So now we know the answer to that. Next, in terms of ACS, so acute coronary syndromes, when they are managed medically, and not, there's no surgery involved, so no cabbage, no PCI, then what we would be doing is we would be giving a person aspirin plus ticagrelor, 90 milligrams twice daily for 12 months. It could be continued up to 36 months at a lower dose of the ticagrelor, which is 60 milligrams twice daily. This is only for patients with a high risk of ischemia. Now, in your exam, how are you going to know that a patient has got high risk of ischemia unless they tell you? Okay, if they say to you, a patient has got high risk of ischemia, then understandably, they may ask you, how long could this be continued for? Does that make sense? And hopefully that answers question one. There are other things, of course, also to be aware of with this in terms of stroke and TIA. I think is the key thing that you want to learn there is with strokes that specifically are ischemic or transient ischemic attacks even, it would typically be clopidogrel alone, so it's not dual antiplatelet therapy. However, if it is not tolerated for whatever reason, we could give disopyramidol plus aspirin in that case, or if that disopyramidol is not indicated, then we would give aspirin alone. Now, key point to remember is with prasugrel, the dose should be reduced in patients that are under 60 kilos or over the age of 75 from 10 milligram daily to 5 milligram daily, as well as if patients develop GI side effects and they've not got any red flags, and let's say somebody's taking clopidogrel following a TIA, so they're on clopidogrel for life now. So what kind of PPIs would we want to be avoiding? There's two particular ones that I'm thinking about. So this is getting you to think hopefully a little bit about interactions. Omeprazole, and there's one more. Sounds very similar to it. Esomeprazole. Excellent, excellent, good. Cool. So hopefully that's these two questions answered. I'm just going to have a quick look through the chat. I know there's a question here before. Stroke and TIA question. When a person has a TIA, people with a bleeding disorder or taking an anticoagulant should have an urgent computer tomography to exclude hemorrhagic. Should a person here wait for a scan before taking aspirin 300 milligram? Good question. This question I answered during the webinar that I recorded. I will answer it again. So the only way that you are going to know that a patient has had a TIA will be if a patient came to you and said the symptoms resolved, and they were the obvious fast symptoms that we'll come on to in a few slides to come. Okay, then you know it's a TIA. There wouldn't necessarily be a need for computer tomography there because the symptoms have resolved and they were the fast symptoms of facial drooping, etc. Does that make sense? Understandably, if it was hemorrhagic and if it was a stroke, the symptoms are not going to be resolving. The patient, understandably, is still going to have symptoms. They're unlikely to appear to a community pharmacy, or even general practice for that matter. But it is possible though, but they should obviously be referred to hospital straight away. If somebody has a TIA in front of you, you don't know if it's a TIA or if it's a stroke of any kind. So there's no way that you're going to give aspirin because it might be a hemorrhagic stroke. Does that make sense? Hopefully that answers the question that's in the chat. Awesome, cool. I'm glad that makes sense. So let's move on then. I've got a couple of slides that I pulled across from the session that I think are really important and just kind of really illustrate the level of detail that I try to go into within these sessions. So let's talk about hypertension. Okay, when it comes to hypertension, it's all about the stages. When it comes to diagnosis, so how worried are we on a scale of 1 to 3? Think of it like that. We've got stage 1, 2, and 3. And we already know the stages in terms of the blood pressure readings, I hope. The first one is 140/90, or ambulatory/home blood pressure reading average of 135/85. Stage 2, you add 20 to the upper number, 10 to the lower number, so over 160, so greater than 160/100, or a home/ambulatory home blood pressure monitoring average of 150/95. And stage 3, which you might have thought of as or know as hypertensive crisis, that is when there is either a systolic blood pressure of greater than 180 or diastolic of greater than 120. Now, a really key point is patients with stage 3 often need referral, of course, for urgent assessment, especially if they have any of the following symptoms. So new onset confusion, chest pain, signs of heart failure, or acute kidney injury, or signs of retinal hemorrhage or papillary edema. Now, understandably, let's think you diagnose a patient, let's say, with hypertension, right? What are the tests that you think we should arrange for that patient in the coming weeks, just to rule out any targeted end organ damage? What can we do? Assume you're in general practice, because typically that's where hypertension is quite often diagnosed, but you could even be in community pharmacy, especially with the new schemes that are around these days with the home blood pressure monitoring cuffs that are provided by community pharmacies. So what kind of tests should be performed on patients newly diagnosed with hypertension? What do we think? Say it's stage 2. So you don't know how long the patient's had the hypertension for, right? So we want to be looking at end organ damage. So when we talk about end organ damage, we've got the 1, the cardiac muscle itself, 2, the kidneys, and 3, the eyes. They're the key ones that you want to be looking out for. Okay, so by looking at stage 3 hypertension, right, and all the key points that I highlighted to you just a few moments ago, there's only really 3 organs that are being targeted there. Apart from the new onset confusion, of course, we've got the cardiac system, which is chest pain / heart failure. We've got the kidneys with the acute kidney injury, and we've got signs of retinal hemorrhage or papillary edema with the eyes. So what you would do is you would arrange an ECG, right? That's going to tell you about the electrical function within the heart. Have they got left ventricular hypertrophy? Because what ends up happening with the heart is, like any muscle, as it gets overused or even abused in this case, in fact, I would say, what happens is it will grow and it'll become hypertrophied. And what that means is, as the muscle thickens, the electrical impulses don't flow as well. Okay, and this is often what leads on to patients developing a heart failure because of left ventricular hypertrophy. The heart muscle is not contracting effectively anymore because within that hypertrophied muscle, the neural network or the passage of the electrical flow, you could say, within the heart is not quite the same. Okay, so that can become one of the causes of the development of heart failure later on down the line. So one thing we're going to do is we're going to recommend an ECG. How about kidney function? How can we test kidney function then? We can do, what can we do to test kidney function? We can do ... Let you guys complete the sentence. There's 2 things, and they're both things that come out of the body. One thing flows out naturally, and the second thing we usually take out with a needle. We are going to analyze the patient's urine for albumin creatinine ratio. So is there any albumin in the patient's urine? So are the kidneys leaky, suggestive of targeted end organ damage, or they're not leaky? So there's no target end organ damage, right? So that hopefully is quite clear and quite straightforward. And if it is, of course, we're just going to manage depending on if we need to refer or not, depending on the level. Secondly, it's use and ease, right? We're going to see, are the kidneys still functioning well enough to be able to manage and stabilize the electrolytes and urea within the body, as well as review the EGFR from looking at them readings. Okay. Does high albumin in urine confirm end organ damage? Yes, chronic high levels of albumin in urine confirms end organ damage. So have a look at the CKD page on CKS, and in recent years, a long time ago, what just used to be looked at was the EGFR and creatinine clearance for that, in terms of saying, is it stage 1, 2, 3, 4, etc. of CKD? But now we look at it in terms of what's the EGFR or creatinine clearance? So how well are the kidneys functioning themselves? Secondly to that, how leaky have the kidneys become due to end organ damage? Hopefully that makes sense. Often what actually ends up happening in patients is, as opposed to hypertension alone, there's often a mixture between hypertension and diabetes, which is what I see quite commonly in clinic, in fact. And one thing, being an advanced clinical practitioner, that I think I have a greater appreciation for is the kidneys themselves, and understanding how the albumin creatinine ratio can change when we manage somebody's hypertension better, or we put them on an ACE inhibitor, even a low dose. So if somebody has a high albumin creatinine ratio and you put them on an ACE inhibitor, often that'll improve and they will become better. So you could say even the kidney itself, of course, is healing per se. Okay, so if obviously we were to remove the ACE inhibitor again, more likely than not, they would have the effects reduced or reversed even, and therefore lead to more albumin within the urine again. Third thing was then, lastly, is the eyes. We don't test for eyes usually within general practice. Often we'll end up actually referring patients to go have a regular eye test unless they're getting specific symptoms suggestive of intracranial hypertension, which you're going to be looking for out for symptoms such as halos around lights. That's a really key one. Um, Understandably, if somebody's having a retinal hemorrhage, that's definitely a red flag, especially if they've got high blood pressure. Okay, and you can obviously, of course, have a look into the back of the eye for the optic disc as well, but that's well beyond the scope of the GPHC exam. Okay, so they're the key things you want to be remembering in terms of end organ damage and what organs we specifically look at, which is typically heart, eyes, and kidneys, and the different tests and such that we can do. Now, in terms of management then of hypertension, key thing is all patients, right, with hypertension should be advised on lifestyle, which includes diet, exercise, stress management, alcohol consumption, smoking cessation if it's appropriate. Now, in terms of diet and exercise, I'm sure you guys already know 5 fruits and veg. Make sure you're exercising 30 minutes or so a day for about 5 days a week or so. Now, if a patient, this should of course be tailored to the patient themselves and their level of physical activity at present. If somebody's really inactive, it's not sensible to say exercise 5 times a week at 30 minutes because they might go really, really intense. So they just need to do activity to mild breathlessness to start with, and then increase as they become more active and as their cardiovascular reserve improves. Okay. Other things could be such as lifestyle is reducing caffeine intake, as of course that can increase the blood pressure itself. Be aware of any other caffeine-rich products that the patient may be taking as well as things such as energy drinks and things like that. Ensure that dietary sodium is reduced if somebody is having lots and lots of salt in their food. Sometimes patients end up substituting with potassium salts just to give them that salty kind of taste. However, that isn't very useful in most patients, especially if they're on a potassium sparing diuretic. Can obviously cause the potassium level in the blood to rise. Okay. In terms of alcoholic excess, even in terms of lifestyle, that can actually also lead to increasing blood pressure. So reducing intake is quite important there as well. What's the NHS recommendation for the amount of units that somebody can drink in a week currently, male or female even? Because it's the same for both these days, isn't it? What's the units? Excellent. Yep, 14 units. Perfect. So then, let's get on to the crux of the matter. We're pharmacists, and what do we like? We like drugs, right? So in terms of the management of hypertension, first line, it is ACE inhibitor or an ARB for all patients under the age of 55 years or patients of any age who have type 2 diabetes. Okay? So if you've got a 60-year-old patient that's now got hypertension, but they've also got diabetes, you're going to start them on a ACE inhibitor or an ARB. Okay? Now, for any step and any stage, you want to be avoiding ACE inhibitors in patients of a Black African or Afro-Caribbean patients, okay, if they've got that type of descent. Alternatively, for all patients that are above the ages of 55, no history of type 2 diabetes, we're going to be giving calcium channel blockers, more likely than not, amlodipine, okay? Now, second line treatment options. You're going to be either offering an ACE inhibitor, calcium channel blocker, or thiazide-like diuretic. Understandably, it just depends on whatever you give the patient at first line. What you're going to do is, before you move on to second line, is ensure the patient's got good compliance. they're taking the medication regularly as prescribed, and that the dose has been titrated to the maximum tolerated. So for example, let's say somebody's on ramipril, um, 5 milligram. When we tried to increase it to 10 milligram, the renal function declined. So we went back down to 5 milligram. So 5 milligram for that patient is the maximum tolerated dose. So then they would have to move on to stage 2. Hopefully that makes sense. Next, we would offer a combination of all three of these. So they might be on ramipril, 5 milligrams, amlodipine, 10 milligrams, and then a thiazide-like diuretic such as indapamide. Fourth line depends on the patient's kidney function and their potassium levels. So if their potassium level is less than 4.5 millimoles, we can add in spironolactone because that's naturally going to push up the potassium level slightly. If it's greater than that, then we can either add in an alpha blocker, such as doxazosin, for example, is quite commonly used, or a beta blocker. Okay. Now then, in terms of target readings, it depends how old the patient is. So if somebody is less than 80 years old, we want a target reading within clinic of less than 140/90, or a home blood pressure reading of less than 135/85. If somebody is over 80, then of course we have a bit more leeway. We have a clinic reading of less than 150/90, or a home blood pressure reading of less than 145/85. Okay, so hopefully that makes sense, and that kind of clears out everything that pretty much you need to know regarding hypertension. And hopefully you've also taken some notes whilst I've been speaking. The only thing I think that's not on the slide is oh, actually, we've literally just gone through it. It's the hypertension target for people that are over the ages of 80. There's usually 150/90. The only reason for that obviously being the fact that there's an increased risk of falls in that particular age demographic. So of course we don't want to be increasing the risk of falls by pushing the blood pressure down a little bit too much. Okay, cool. Let's move on then. Unless you guys have got questions, we just stick them in the chat. We'll just answer them as we're going along. So the next question, or the next slide that I went through during the session was, or one of the next slides, I think it was after about 5 or 6 slides or so, something like that. But anyway, it's all about strokes, okay? So what is the definition of a stroke? So a stroke is a clinical syndrome that is caused by a cerebral infarction or hemorrhage, so a stoppage of blood flow or bleeding, in other words, within the brain. It's typified by rapidly developing signs of focal and global disturbances of cerebral functions that last more than 24 hours or lead to death before the 24 hours are up, of course. Now, signs of focal disturbances, okay? So give me one sign of a focal disturbance when it comes to stroke. Something specific. It is slurred speech, right? Slurred speech is a focal symptom, right? Because it's more to do with the mouth. However, there could be a global disturbances where you get unilateral limb weakness, okay, depending on which side of the brain the patient is being affected by. Okay, now, how do we define a stroke versus a TIA? Key things to remember is timing, okay? When it comes to a stroke, it lasts more than 24 hours, okay? That's regardless of an ischemic stroke or even a hemorrhagic stroke for that matter. In terms of a TIA, the symptoms will resolve in less than 24 hours, usually 5 to 15 minutes or so typically, okay? Now, I think this relates back to the question that was asked previously, so I'll reiterate the answer for anybody that did miss that. The question that was asked was, if somebody's having a stroke, do you give aspirin or not, or do you have to wait for the CT imaging to know if it's a hemorrhagic or ischemic or TIA for that matter? The thing is, if somebody's having a stroke in front of you, at that moment, you do not know which of the three it is. So therefore, you would not give aspirin. Understandably, if it does end up being a hemorrhagic one and you've given aspirin, we're only going to be making the bleeding worse. So therefore, if somebody's having a stroke in front of you, then therefore we will not be giving aspirin. However, if somebody says, I had the symptoms of facial facial drooping, my whole left side of the body went weak, my speech was slurred, and this all happened, I don't know, 2 days ago. Therefore, it must be a TIA. Okay, it happened 2 days ago and it lasted 15 minutes, let's say. And then it became better, so I didn't go to see my GP and I've came to see you in the community pharmacy. Then you can be certain that this patient must have had a TIA, right? That's when you can give the aspirin. Hopefully that makes sense. And then in terms of the ongoing management of this and where you would refer to and in what time frame they would need to be seen, you can see this in the cardiovascular session where I go into a lot more detail. But hopefully that's just a bit of an overview for yourselves there. Finally, one last slide that I'm going to share with you guys that's also on our social media page. I think it's kind of buried in all the other recent posts that we've done. It's this one that's coming up here. So this is a really, really useful one, I would say, for revision. So this is an amalgamation on the use of statins, antiplatelets, and anticoagulants for common chronic diseases. So that question that I asked you before of when is an antiplatelet used, this this diagram basically answers it for you. Okay, so we've got MIs, angina, if somebody's got peripheral artery disease or peripheral vascular disease, or if somebody's had an ischemic stroke, or if they've had a TIA, all right? And we've discussed previously which antiplatelet is selected for each of these scenarios. Hopefully you were making notes. If not, watch the recording of this session. And if you are watching the recording, just rewind the video. Secondly, the use of statins. Okay, when do we use a statin? Key thing to remember with statins and Q-risk is that if you're using something like Q-risk, and let's say we're talking about a patient that's 40 years old, right, and the Q-risk is less than 10%, then I think we'd want to be considering using a statin more strongly than if a patient was 70 years old and the risk was less than 10%. Reason being is Q-risk just as your cardiovascular risk over the next 10 years or so. Okay. Now, if somebody's got greater than 10%, that's really straightforward, isn't it? Yep, greater than 10%, recommend the patient should start a statin. But for younger patients, right, we would also want to consider them starting a statin if the Q risk was less than 10%, because the overall risk within their lifetime is going to be greater than whatever the Q risk is saying. Okay, because if the Q risk is saying 3%, and we don't put the patient on a statin, and let's just say this particular patient is not reviewed again for the next 10 years for whatever reason, their overall risk is going to be a lot higher, isn't it? So let's just go back to that slide again for a few minutes. So hopefully that makes sense, okay, in terms of Q risk and statins. And we obviously, understandably, we know primary prevention versus secondary prevention, doses of statins, hopefully. So let's see if you guys remember what I was saying earlier. So let's say somebody's got peripheral vascular disease. What will we be using for that patient? Peripheral vascular disease. What kind of antiplatelet will we be using? What's the first line option? I named to you guys about 5 of the antiplatelets before. Let's see if you remember. Excellent. Excellent. It is clopidogrel. So well done, Sukh. It is clopidogrel. What's the alternative then? Really easy. PVD, PAD. Somebody's not tolerating clopidogrel. Or they're saying, I don't want to take clopidogrel because you're telling me it's not going to work alongside my aspirin. It's not going to work alongside my omeprazole, and omeprazole is the only PPI that works for me, doctor. So I don't want to change my omeprazole. 40 milligrams is the only dose that works for me too, and I'm not moving down. So I can't have the clopidogrel because you've told me the antiplatelet effect of clopidogrel is reduced by omeprazole. So what's the alternative? The alternative is 5 seconds. 3, 2, 1. Aspirin. Fantastic. Well done. You just got in the nick of time. Good. Excellent. Secondly, following an ischemic stroke or TIA, what is the antiplatelet of choice? Any other guesses? We've got one bid for aspirin. Is anybody else bidding on aspirin? We've got 2 bids for aspirin. Unfortunately, guys, aspirin's not the correct answer. Following an ischemic stroke or a TIA, the first line option is clopidogrel. Clopidogrel. I'll come on to ticagrelor in a minute. So, and this is the one. There's another antiplatelet. It's the one that I couldn't remember the name for. Starts with D. Let's say the first line option is clopidogrel. Same patient again. They're saying, doctor, you're telling me you want me to change my omeprazole, but I've tried all the other PPIs and nothing's worked for me. So therefore, I can't have clopidogrel because I don't want to change my omeprazole. What's the second line option for patients that cannot take clopidogrel for a previous history of ischemic stroke or TIA? What do we think? Excellent, Elaine. That's the one that I couldn't think of. Dipyridamol. But is it dipyridamol alone or is it dipyridamol in conjunction with something else? Well remembered though. With aspirin, cracking, great stuff. Excellent. We're all on the same page now. We're all learning because these are the types of things that students get tripped up on, and these are the types of things that they can ask you questions on. Okay, so they could make a whole list of different antiplatelet combinations and some antiplatelets that are alone and say which one of these would be recommended in a patient that's had a history of ischemic stroke. Okay, so this is the level of detail that I think you guys should be pitching towards. Let's say, next question was, oh yeah, somebody mentioned something about ticagrelor. Okay, when did I say that we would use aspirin and ticagrelor? Following what? And this is the bit where the confusion sometimes comes in with students because we talk about 12 months and 36 months and stuff like that sometimes. So I said it when we were talking about acute coronary syndromes in patients that are being medically managed. Okay, so if somebody's having a heart attack, STEMI or an NSTEMI for that matter, normally with a STEMI, patients have some sort of surgical intervention or PCI. So that's when you hear about CABG, coronary artery bypass grafts, or you'll hear about percutaneous coronary interventions. So PCI is basically you're trying to clear the blockage. CABG is a surgical intervention where you're going in and grafting vessels to literally bypass that section where the blockage is, in essence. So quite straightforward, really, to understand that part of the concept anyway. When it comes to the medically managed STEMI or NSTEMI, that's when we talk about ticagrelor, okay, in combination with aspirin, and if it needs to be continued for a duration longer than 12 months, and the dose would be reduced from 90 milligram twice daily to 60 milligram twice daily after 12 months. It may be continued up to 36 months. Understandably, it's only going to be for patients that are a high risk of ischemia. and a low risk of bleeding, understandably too. So they've not had any bleeds within the last 12 months and they've tolerated things really well. Then of course we would want to consider um, increasing the duration of the DAPT, especially if normally they would have been a candidate for cabbage, but they're not. Um, so things that would rule somebody out, understandably, would be if the surgeons just don't think the patient's going to survive the surgery, and that just could be because they're very complicated or they're very elderly, or they just won't survive for any other particular reason. Okay, so hopefully that makes sense. Let's see if there's any other notes that I made. Um, if somebody also actually has a PCI, sometimes it's considered to increase the duration of their DAPT as well. So medically managed acute coronary syndromes, or if somebody has a percutaneous coronary intervention, that is when we will want to consider DAPT being continued for longer than 12 months. And both of these are usually done um, following some sort of acute coronary syndrome, so typically MI, but obviously also could be for angina. Main differences between cabbage and PCI is the fact that there's more options for DAPT when it comes to PCI. So with percutaneous coronary interventions, the options of the secondary antiplatelet alongside the aspirin, you can pretty much use anything really. However, that's not going to be something you're going to be asked about in your exam, but just for your own knowledge, for anyone that wants to know. So either prasugrel or the ticagrelor or even clopidogrel for that matter. Okay, so hopefully that makes sense. Um, any other questions regarding that, or any questions in general? I've just realized the time. Feel free, you guys, just throw them into the chat. Let me pause this, have a jump over to Slido. Or in fact, I'll have a look at Slido on the other screen, see if anything's asked there. If you guys have got anything else you want to ask, just throw it into the chat, really. More than happy to answer any questions. Excellent. I'm glad you've enjoyed it. Hopefully other people have enjoyed it too. Hopefully it's been informative. But yeah, if you found this good, I did the cardiovascular session as well, and I think you'll probably enjoy that too if you found this quite useful. But you don't have to like anything, guys. You don't have to purchase any of the courses. You don't have to actually, factual statement, you don't need to pay any money to pass the pre-reg exam. Okay, apart from paying the GPHC to be able to sit the exam. Okay, and I can write that on stone for you. And you might think, well, this guy needs to make money or something. It's genuinely, it's not about that. Thankfully, I'm very lucky. Being an ACP, you make a very good income. So I do this to be able to give something back, especially these free sessions. I really enjoy them, and I hope you guys do too. But I genuinely do not say that you have to pay. I think the later you start, the advantage of paying increases. I don't think you're too late to not have to purchase a course in January. I think if somebody starts revising, let's say March, I would definitely purchase a course if I was a student. If I was starting to revise in March, because March is really, really late. The advantages of purchasing a course, okay, and they are only this. All the information I've given to you guys, it's not research based, right? I've not gone out there and done research per se and modeled, oh yeah, I've done some sort of massive study on several thousands of patients and then given you the knowledge. It's not that level. The level that you guys need to know is all about the guidelines, looking at CKS, looking in your BNF, looking even on NHS choice. Okay, they're the kind of things that you need to be looking at. Now, do you have enough time from now to the exam? You definitely do. Do I think things will probably be easier if you buy a course? Yeah, they probably will. But do you have to buy a course? No, you don't. Will you maybe enjoy the journey of learning by not buying a course? Yeah, I think sometimes it'll be frustrating, but looking around different resources, you can definitely do it for free. So yeah, hopefully that's okay. Hopefully that makes sense. I've had a look on Slido, guys. There's no questions there. So I'm gonna end the session now. I'm just gonna have a quick look over. So somebody just asked a question. For revision, would you cover the high weighted first and then the medium, then low? I wanted to purchase cardio. I need your knowledge. Um, you don't have to purchase any of the sessions. Really, you don't have to. But if you want to and you think that all the information's, I try to put in as much as possible and really jam pack things in, as do all of the other tutors. I do moderate a lot of the content anyway. Yeah, then feel free to go ahead. But of course, if you want to look at the resources that we looked at to create the sessions, feel free to do that too. Often in the sessions, we go over scenarios and case studies, which can be quite engaging and enjoyable, I would say, as a student, and you can kind of link things together and have a more broader understanding of a topic, which is really good, especially within the exam. So it's kind of setting your mindset right for the exam. The other way you can do that is by purchasing a mock. I would say purchase 2 mocks if you can. Definitely do it by some sort of reputable company. It doesn't have to be by us, but knowing the fact that we also work in academia is quite useful, I would say. Um, I have full time on the exam, done the placement. I need guidance. Yeah. I think if you've got full time just to revise, I think it's a lot of time that you've got, and if you've got nothing else to do in terms of a placement, then I probably would purchase a course if you've got the expendable income. If you've not got the expendable income, you don't have to purchase a course. It's not the be all end all if you've purchased a particular course or not. I mean, people that did purchase this course, I think the pass rate that we had last year was around 90% or so. So that was for people that purchased the whole course and attended the whole course as well as really engaged. But yeah, so that brings us to the end of this question and answer session. So we have clocked off over the counter masterclass, genitourinary immunity and malignancy, gastrointestinal respiratory systems, and now cardiology. Hopefully that was enjoyable. Hopefully you've had a good time. And we will be seeing you on endocrine. It's my colleague Katie that'll be leading that session, as well as the feedback for that session. I will be doing blood nutrition and MSK, and I've been doing lots and lots of reviewing lots of bloods at work. So hopefully I'll try and give you that experience in there too. I am gonna end the recording as soon as I figure out how to do that. If you've got any other questions, throw them in the chat. I'm going to be around for another couple of minutes to answer. But yeah, thank you again for attending. If you want to purchase the course, feel free to jump over to the website.